Gastritis Marie Alborum, MD, ed., MPH, MACP, FACG, AGAF Jenny Dave, MD, MS Basics Description. Inflammation of the gastric mucosa can be classified by time course, acute versus chronic, acute, neutrophilic infiltration on histology, chronic, mixture of mononuclear cells, lymphocytes, macrophages on histology. Multiple types of gastritis have been described. There is no universally accepted classification for gastritis. Subtypes of gastritis include erosive gastritis or reactive gastropathy, mucosal injury by a noxious agent, especially nonsteroidal anti-inflammatory drugs, NSAIDs or alcohol, or vascular congestion and/or mucosal ischemia, damage to the surface epithelium caused by mucosal hypoxia or the direct action of NSAIDs with no associated inflammation. Reflux gastritis, a reaction to protracted reflux exposure to biliary and pancreatic fluid, typically limited to the pre-pyloric antrum. Hemorrhagic gastritis, stress ulceration, a reaction to hemodynamic disorder, e.g., hypovolemia or hypoxia shock, common in intensive care unit, ICU, patients, particularly after severe burns and traumas, seen rarely with certain medications, e.g., dabigatran, an oral thrombin inhibitor. Infectious gastritis, acute and/or chronic Helicobacter pylori infection, most common cause of gastritis, viral infection, reaction to systemic infection, phlegmonous gastritis. Atrophic gastritis, autoimmune versus environmental, frequent in the elderly primarily from long-standing H. pylori infections. Prolonged proton pump inhibitor, PPI, use. Major risk factor for gastric cancer associated with primary, pernicious, anemia. Geriatric considerations, persons age greater than 60 years often harbor H. pylori infection. Pediatric considerations, gastritis rarely occurs in infants or children, increases in prevalence with age. Epidemiology. Predominant age, all adult ages, more common in elderly. Predominant sex, male equals female. Incidence accounts for 1.82.1 million medical visits each year in the United States. Prevalence, gastritis is more prevalent in those greater than 60 years of age. Prevalence of 50 to 60% by age 60. 30-35% of U.S. adults are infected with H. pylori. Rates of infection are higher in minority groups and immigrants. Prevalence also higher in lower socioeconomic status. Etiology and pathophysiology. Noxious agents cause a breakdown in the gastric mucosal barrier, exposing epithelium to injury. Infection, H. pylori, most common cause, Staphylococcus aureus exotoxins, and viral infections. Alcohol, aspirin and other NSAIDs. Bile reflux, pancreatic enzyme reflux. Portal hypertensive gastropathy. Emotional stress, hemodynamic instability, hypoxemia, genetics unknown, but observational studies show that 10% of a given population is never colonized with H. pylori, regardless of exposure. Genetic variations in TLR1 may help explain some of this observed variation in individual risk for H. pylori infection. Risk factors: age greater than 60 years, exposure to potentially noxious drugs or chemicals, e.g., alcohol or NSAIDs, hypovolemia, hypoxia, shock, burns, head injury, complicated postoperative course. Autoimmune diseases, thyroid disease and diabetes, family history of H. pylori and/or gastric cancer. Stress, hypovolemia or hypoxia, tobacco use, radiation, ischemia, pernicious anemia, gastric mucosal atrophy. General prevention: avoid injurious drugs or chemical agents including but not limited to alcohol and tobacco. Patients with hypovolemia or hypoxia, especially ICU patients, should receive prophylaxis with H2 receptor antagonists, proton pump inhibitors, prostaglandins, or sucralfate. Consider testing for H. pylori, and eradicating if present, in patients on long-term NSAID therapy. Commonly associated conditions: gastric or duodenal peptic ulcer, primary, pernicious, anemia, atrophic gastritis, portal hypertension, HTN, hepatic failure, mucosa-associated lymphoid tissue, MALT, lymphoma. Diagnosis: history, epigastric discomfort, often aggravated by eating, burning, epigastric pain, anorexia, nausea, with or without vomiting. Significant bleeding is unusual except in hemorrhagic gastritis. Rectal bleeding/melena, hiccups, belching, bloating or abdominal fullness. Unintentional weight loss. Physical exam. Vital signs to assess hemodynamic stability. Abdominal exam often normal. Mild epigastric tenderness may have heme-positive stool. Examine for stigmata of chronic alcohol abuse. May have pallor, slowing of capillary refill if patient is anemic. Differential diagnosis. Functional abdominal pain, dyspepsia, peptic ulcer disease, viral gastroenteritis, gastric cancer, elderly, cholecystitis, pancreatic disease, inflammation versus tumor, diagnostic tests and interpretation. Initial tests, lab, imaging, usually normal. Complete blood count to evaluate for blood loss/anemia. Stool analysis for fecal H. pylori antigen. 95% specificity and sensitivity can be used for diagnosis and eradication. 13C urea breath test for H. pylori. 95% specificity and sensitivity. H. pylori, serology. Serum IgG inexpensive, 85% sensitivity, 79% specificity. Positive in history of colonization or prior infections, cannot be used to assess eradication. Gastric acid analysis may be abnormal but is not a reliable indicator of gastritis. Low serum pepsin I, PGI, relative to PG2 is associated with fundal intestinal metaplasia. Patients with autoimmune chronic gastritis may have antibodies to intrinsic factor or parietal cells, with elevated serum fasting gastrin level. Drugs that may alter lab results, antibiotics or PPIs may affect urea breath test for H. pylori. Hold PPIs for 2 weeks, H2 receptor antagonists for 24 hours, and antibiotics for 4 weeks prior to stool or breath tests. 1. C. Follow-up tests and special considerations. Endoscopy for H. pylori. Obtain biopsy for culture, polymerase chain reaction, PCR, histology, rapid urease testing. Diagnostic procedures/other. Gastroscopy with biopsy is first-line diagnostic tool in age greater than 50 years with new onset signs and symptoms. 2. Weight loss, persistent vomiting, or GI bleed. 1. C. Gastroscopy with biopsy should also be considered for patients 50 who are H. pylori negative. 2. Gastric biopsies, multiple, in both body and antrum recommended if there is a poor response to initial treatment. Patients must discontinue PPIs for 2 weeks prior to endoscopy to improve diagnostic accuracy. Test interpretation. Acute or chronic inflammatory infiltrate in gastric mucosa, often with distortion or erosion of adjacent epithelium, presence of H. pylori often confirmed. Ulcers or bleeding may be present. Biopsies from both the antrum and body of the stomach. Treatment. General measures. H. pylori treatment is required to relieve symptoms. Parenteral fluid and electrolyte supplements. If unable to tolerate oral intake, discontinue NSAID use if possible. Abstinence from alcohol, smoking cessation. Endoscopy in patients not responsive to treatment medication. First-line antacids, best given in liquid form, 30 ml 1 hour after meals and at bedtime, useful mainly as an emollient. H2 receptor antagonists, e.g., cimetidine, Tagamet, oral cimetidine 300 mg Q6H, or ranitidine. Zantac 150 mg BID or famotidine. Pepsid 20 mg BID or nizatidine. Axid, 150 mg BID not shown to be clearly superior to antacids. Sucralfate, carafate 1 g Q46H on an empty stomach, rationale uncertain but empirically helpful. Prostaglandins, misoprostol cytodic can help allay gastric mucosal injury, dosage 100 to 200 μg QID. PPIs if no response to antacids or H2 receptor blockers, e.g., omeprazole 20 mg daily or BID or esomeprazole 20 mg daily or BID. H. pylori eradication. Clarithromycin triple therapy, CTT, a short course therapy, 10 to 14 days, of amoxicillin 1 g BID, standard dose PPI BID, omeprazole 20 mg BID, etc., and clarithromycin 500 mg BID. 3. A 70–85% eradication. Optimal treatment still undefined if PCN allergic. Substitute amoxicillin with metronidazole 500 mg TID. Bismuth quadruple therapy, BQT, PPI, omeprazole 20 mg, BID plus bismuth, Pepto-Bismol, 30 ml liquid or 2 tablets QID plus metronidazole 250 mg QID plus tetracycline 500 mg QID for 10 to 14 days. 3. A 75-90% eradication use as initial therapy in areas of high clarithromycin resistance. 15%. Consider in penicillin allergic patients. Alternative H. pylori treatment, sequential antibiotic therapy with standard dose PPI, i.e., omeprazole 20 mg and amoxicillin 1 gram BID for 5 days followed by clarithromycin 500 mg and tinidazole mg BID with standard dose PPI, omeprazole 20 mg, BID for 5 days, equivalent to triple therapy. 1. B, 3. AH. Pylori treatment failure, use a different regimen, avoid clarithromycin, unless resistance testing confirms susceptibility BQT for 7 to 14 days. 1,3. A, consider levofloxacin 250 mg BID, amoxicillin 1 gram BID, and standard dose PPI BID for 14 days in those who fail twice. 1,3. A. In those allergic to penicillin, consider levofloxacin quadruple therapy with levofloxacin 250 mg QD, omeprazole QD 40 mg, nitazoxanide 500 mg BID, and doxycycline 100 mg QD for 7-10 days. 4. B. Consider probiotics in known symptomatic H. pylori. May decrease density of H. pylori in gastric antrum and body, decrease severity of gastritis, peptic ulcers, and possibly slow progression toward atrophic gastritis and gastric adenocarcinoma. 5. C. Probiotics alone likely do not eradicate H. pylori. Possible regimens as used in trials. Bifidobacterium infantis BID times 14 days. Contraindications. Hypersensitivity precautions. Bismuth may turn stool black. The manufacturer's profile of each drug lists precautions and potential drug interactions. Surgery/other procedures. Surgical intervention is not necessary, except in the case of phlegmonous gastritis or gastritis with high-grade dysplasia. Complementary and alternative medicine. Some studies suggest cranberry may inhibit the growth of H. pylori. Admission, inpatient, and nursing considerations. Prophylaxis in ICU patients. Outpatient management, except for severe hemorrhagic gastritis. Ongoing care. Follow-up recommendations. Usually no restrictions. Confirm H. pylori eradication 4+ weeks after treatment. Patient monitoring. Consider repeat endoscopy after 6 weeks if gastritis was severe or if poor treatment response. Surveillance endoscopy every 3 to 5 years in patients with atrophic gastritis in both the antrum and body, within 1 year for patients with low-grade dysplasia, with extensive biopsy sampling. Endoscopy at 6 and 12 months for patients with high-grade dysplasia. 25% of patients with high-grade dysplasia may progress to adenocarcinoma within a year. It is recommended patients with confirmed high-grade dysplasia undergo surgical or endoscopic resection. 6. C. Surveillance may be suspended when 2 or more endoscopies are negative for dysplasia. 6. C. Diet restrictions, e.g., bland, light, soft foods, depend on symptom severity. In general, avoid caffeine, spicy foods, and alcohol. Patient education. Smoking cessation, limit alcohol. Dietary changes. Relaxation therapy. Avoid NSAIDs if possible. Prognosis. Most cases clear with identification and treatment of the underlying cause. One exception is phlegmonous gastritis, which has a 65% mortality even with treatment. Recurrence of H. pylori infection requires a repeated course of treatment. Complications. Bleeding from extensive mucosal erosion or ulceration. Gastric outlet obstruction due to edema limiting adequate transfer of food from stomach to small intestine. Presence of H. pylori may lead to gastric intestinal metaplasia, which puts patient at a 10-fold increase of developing gastric cancer. Clearing H. pylori before the development of chronic gastritis may prevent development of gastric cancer. Chronic autoimmune gastritis has increased risk for development of gastric neuroendocrine tumors and adenocarcinoma due to dysplasia. Reference